Hello, everyone. Thank you so much for joining us for our first webinar of 2023. I am Michelle Williams, and I am currently the chair of the Women's Caucus, and we are hosting this fabulous webinar today. This is the first in our 2023 Critical Issues in Women's Health webinar, and this webinar is featuring our 2022 highest scoring abstract award winners who did these presentations during the APHA Annual Conference, but because they're so fabulous, I wanted to make sure that everyone had an opportunity to see this amazing work that's being done in this area of women's health. And so just a little bit about the Women's Caucus, for those of you who are not familiar, the Women's Caucus is a partner with APHA. Our goal is really to focus on issues related to women's health that are not often considered as important and not often discussed. So that's why we have these types of webinars. And if you do not already follow us on social media, if you're not already a member and you're interested in learning more about us, you can check us out on our social media sites or visit our website. Also, in case you're interested, we will be having our first quarter executive committee meeting on February 10th at 1 p.m. Eastern Standard Time. And this is open to all of our members. And we encourage our members to come because this gives you an opportunity to learn about ways that you can get involved with the things that we're doing throughout the year. So if you're interested in that, you can visit our social media sites, and it has more information about how to register for this meeting. And also, if you are going to be presenting research at APHA in the fall of 2023, we encourage you to submit your abstract to the Women's Caucus. Again, you can visit our website or our social media sites to find our call for abstracts. And we would love to have you attend and represent for the Women's Caucus. Now I have the honor of introducing our fabulous 2022 award winners. We actually had a total of 6 highest scoring abstract award winners because the abstracts were so fabulous, and we had several ties. But just to let you know that every year we get well over 100 abstracts submitted to us. And so these are the best of the best abstracts. They receive our different highest scoring abstract awards. So our first presenter for today will be Sirat Abu-Hammad. She is a PhD candidate at Bekmuratova University of Negev. She is joining us all the way from Israel today. And the title of her presentation is Maternal Respectful Care and Postpartum Depression Among Postpartum Mothers in Israel. And she is the winner of our honorable mention highest scoring student abstract. Our second presenter for today will be Dorian. She is a PhD candidate at the University of Toledo. The title of her presentation is Who Gets a Choice? Predictors of Undergoing an Episiotomy, a secondary analysis of listening to mothers in California. And she earned the highest scoring student abstract award last year. And our third presenter is Dr. Sarbinaz Bekmuratova, who is an assistant professor at Creighton University, and the title of her work is Challenges of Community Organizations in Serving Youth Survivors of Human Trafficking of Racial Ethnic Minority Youth and Youth with Disabilities. And she earned the honorable mention highest scoring abstract award. And I just have to say this, I have to brag on Sarbinaz. Sarbinaz is one of our fabulous program committee chairs, but she also won this award last year. And again, out of hundreds and hundreds of abstracts, she's producing all this amazing, amazing work. So I always have to brag on her. All right, so without further ado, I'm going to turn it over to our first presenter, Sirat. And also just to let you all know that if you have questions for our presenters, feel free to put your questions in the chat box. We will also have a time after our third presenter for questions and answers. Sirat, take it away. Thank you.
Let me know. Hi, everybody. Let me know that you are seeing my share. It's okay?
Yes.
Okay. Thank you. Okay, I'm Sirat Abu-Hammad, and I'm PhD candidate at School of Public Health in Ben-Gurion University of the Negev in Israel. And my mentor is Professor Nihaya Dawood. She couldn't attend today with us with the webinar, and she apologized. And I will speak about my study about maternal respectful care and postpartum depression among postpartum mothers in Israel. In the beginning, I would like to tell you that this study is a part of a large study conducted by Professor Nihaya Dawood, and we got the Israel Science Foundation funding, and we have the approval of a super ethics community at Ben-Gurion University, and also the Ministry of Health. I will speak about the policy of quality birth and care among and management, maternal respectful care, a little bit about birth experience among women, and the relationship between birth experience and outcome mental health of women after birth. Maternal respectful care, MRC, you will listen from now about this name. It's a program that the WHO conducted and arranged about every woman in the world. And it has 7 categories that every woman should have advanced and high quality health services, including the right without free from violence, abuse, and discrimination. Birth experience among mothers, we know that childbirth is a powerful event of birth may affect women positively or negatively. Mostly it's positive and empowering and pleasant experience, but for some women it can be a strange, difficult, confusion, and even startling feeling. Positive and negative emotions tend to change frequently. And we found that there is a relationship between birth experience and outcome mental health of women after birth. A negative birth experience can cause mental issue and trauma. About 20 and 30% of women reported traumatic labor, and 2 until 6% of women needed psychological treatment as a result of PTSD, post-traumatic stress disorders, and we found in the literature that there is a clear relationship between negative birth experience and postpartum depression. Our main aims were to examine prevalence of MRC, especially disrespectful care and birth experience, positive or negative, among postpartum mothers. To compare MRC and birth experience in Arab and Jewish women in Israel, to explore the relative contribution of different factors to MRC and birth experience, including socio-demographic characteristics, health status, obstetric history, and social support, and to examine the relationship between birth experience, MRC, and mother's mental health outcomes, especially postpartum depression, PPD. We conducted a cross-sectional study between November 2020 until October 21. Our study population was women of the age of fertility who have given birth in public hospitals in the past years in Israel. We include women of the fertility age in Israel who got birth between 37 until 42 weeks. Within a year before the interview, who speak Hebrew or Arabic, and who give their consent to participate, and who have internet access. We make required our women from social media distribution, and we use also a woman's lead an opinion in Arab society and Orthodox. After we receive the interview consent, we interview women face-to-face via electronic questionnaire. We use Qualtrics software by using Zoom or WhatsApp video because it was COVID-19 limitation. After that, when we make data analysis, we use SPSS version 28, normality test, Cronbach alpha, we did the variable univariate, and after that, a multivariate analysis by multiple logistical regression. Our study tools, we used many studies for many tools, For maternal respectful care, we used mother on respect more, for normal and more normal abuse questionnaire, and disrespectful abuse care during facilities, during childbirth in facilities. Birth experience, we used BQ, birth experience questionnaire, and for PPD, we used Edinburgh postnatal depression scales. I will not explain every tool because I don't have much time, but we built from every one variable. For maternal respectful care, we made mistreatment based on ethno-national identity from 3 questions, and mistreatment due to disagreement with the staff medical. And also from the normal abuse questionnaire, we built 2 variables, felt humiliated in healthcare services and racism in healthcare services. From the questionnaire, disrespectful abuse care during childbirth in facilities, we built 5 variables. It's include received ethical rights, midwife support, received information on the guidance, monitored by a midwife, and received procedures by midwife. For birth experience, we built one variable, and we got dichotomized it from a median score to stress and negative experience, and when the score was above the median score 3.62 to positive experience. Edinburgh postnatal depression scales, we dichotomized it for a score above 10 cutoff score. Our sample was 817 postpartum. You can see it's little bit equal, Arab and Jewish women. Here's some characteristics of the women who got in our sample. In the total sample, we can see that the mean age was 31.3 with standard deviation for 0.78, and we have significant differences between Arab and Jewish women. Almost all the women got birth in Israel. All the women, almost all of them were married or cohabiting. Religiosity level, all you can see that we have an equal between the sample, but we have different significant differences between Arab and Jewish. Most of the women was with a university degree, and about more than half of them have a full-time job. Most of the women got birth in COVID-19 period, and most of them reported that they don't have COVID-19 infection, and more than half of the women reported high social support. In our result in the maternal respectful care, we found that about 60% of the women reported that they felt humiliated in healthcare services. About 20% felt racism, 11 mistreatment due to disagreement with the staff medical, and 5% mistreatment based on ethno-national identity. We found significant differences between Arab and Jewish women. More Arab women reported mistreatment based on ethno-national identity, and more Arab women reported racism in healthcare services. But in the other variables, we found that more Jewish women reported that they felt emulated, and more of them reported that they have mistreatment due disagreement with the staff medical. Here we can find that the distribution of disrespectful abuse care measures that 44% of the women reported that they did not receive procedures by midwife, and about 40% did not receive midwife support, and all the parameters. And we found significant differences between Jewish women and Arab women. More Arab women reported that they did not receive information and guidance compared to Jewish women. And you can see that more Jewish women reported that they do not receive midwife support compared to Arab women. In birth experience, we focus on the prevalence of negative birth experience, and we find in the total sample it's about 54%, and it was significantly higher in Jewish women compared to Arab women. Postpartum depression, we found that in the total sample it was 30%, and it was significantly higher in Arab women compared to Jewish women. Here is the summary of univariate association between study independent and postpartum depression. I will not explain everyone, but we found that a higher age and PPD is lower, and when women reported more racism, PPD was higher. In a multivariate regression result for different models of the study, we found that more likely to PPD was women who reported stressful and negative experience. You can see here. And a woman who reported feeling racism in healthcare services were more likely to PPD. Women who reported mistreatment based on ethno-national identity were at risk for PPD. And also Arab women, COVID infection, low self-health, rated health, and low social support was more likely to PPD. In conclusion, this is the first study in Israel that examined maternal disrespectful care and birth experience. Lower scores of MRC and DACF, disrespectful care, were associated with negative birth experience. Negative MRC, DACF, and negative birth experience were associated with PPD. MRC is an important factor for PPD among postpartum women, and it should be considered, especially among minority women. MRC for mothers in the minority world can contribute to quality care and improve birth experience of women from a variety of backgrounds. Our findings could help for developing intervention for improving MRC among women and tailored for minority women. Ethno-national differences we found suggest intervention to be implemented to prevent racism and discrimination in healthcare system and in the minority world. Such interventions are likely to reduce the ethno-national inequality in PPD between women's groups. Thank you.
All right, I will share my screen. Okay, are you able to see my screen? Okay, thank you. All right, so the title of my abstract that I submitted for the 2022 APHA Women's Caucus section is Who Gets a Choice? Predictors of Undergoing an Episiotomy, which was a secondary analysis of listening to mothers in California. So I'd like to thank and shout out my other co-authors, Sativa Banks, who is a PhD student at the University of Toledo with me, as well as our professor, Dr. Monica Palavarapu, who could not join us today as well. This is our first day of classes, so it's a busy week. So first, I would like to say that there are no relationships that I need to disclose. And I would also like to acknowledge that not everyone with the capability to become pregnant identifies as a woman, and that the term women or mothers may be used throughout the presentation to describe the study population and to reflect when the data was collected, but it is not our intent to be non-inclusive. So an episiotomy, for those who are not aware, is a cut between the vagina and the anus during labor and delivery that is made to enlarge the opening during birth. And episiotomies are one of the most common interventions during obstetric care. However, ACOG, the American College of Obstetrics and Gynecology, deemed that it is medically unnecessary back in 2006, I believe. So when this procedure is performed without clinical indication, it can increase the risk of complications during the postpartum period. And oftentimes this is performed without consent or people are coerced into it. And sometimes they often don't even know that an episiotomy was performed. Rates of non-medically justified obstetric interventions have increased without actual improvements in perinatal and maternal mortality. And unfortunately, in the United States, 1 in 6 women actually report experiencing mistreatment, whether that be in the form of physical or verbal abuse, coercion, and lack of informed consent. Obstetric violence and mistreatment can be perpetuated by physicians, nurses, midwives, and other obstetric staff, but I also want to be clear that it can also be performed by other hospital staff who may not even be associated with labor and delivery, for example, security guards or social workers. The aim of this study was to analyze factors that predict one undergoing an episiotomy itself and not being given a choice in undergoing the procedure. We hypothesized that experiencing other forms of obstetric violence would predict whether or not someone received an episiotomy and whether or not they had a choice in the procedure. Our study used the Listening to Mothers in California survey. The data was analyzed in weighted proportions, and we did descriptive analysis in our regression models in SPSS and STATA, and we estimated adjusted odds ratios and 95% confidence intervals. A cross-sectional analysis was used to compare the characteristics of those who, 1, were given an episiotomy during labor, and 2, who were not given autonomy over the procedure. A multivariate logistic regression model was used to test our hypothesis that other forms of obstetric violence predicted receiving the procedure and not having a choice in undergoing the procedure. Our primary outcome variables were the 2, whether or not you received an episiotomy and whether or not you had a choice in receiving an episiotomy. Our predictor variables were whether or not someone had a midwife attended at birth, whether they were pressured to induce labor, whether they were pressured to use an epidural, and whether or not they experienced verbal and physical mistreatment. Our socio-demographic variables of interest were race and ethnicity, the level of education of the mother, insurance status and coverage, and their income. A high proportion, so almost 50% of the births in the Listening to Mothers California study were attributed to Hispanic and Latino women. 28% identified as white, only about 4% identified as Black, and about 15% identified as Asian Pacific Islander, and almost 3% identified as multiple race. Of all of the women who responded to the survey, 21% said that they received an episiotomy. Out of the 21% that received the procedure, 75% said that they did not have a choice. I also want to note that we did not include anyone who did not know if they received the procedure. Women who did receive an episiotomy had higher rates of feeling pressured to induce labor, higher rates of feeling pressured to use an epidural, and higher rates of experiencing verbal and physical mistreatment. Not having a choice and undergoing an episiotomy was most common among those who had Medi-Cal insurance, which is the Medicaid version of health insurance in the state of California, those who felt pressured to use an epidural, and those that experienced verbal and physical mistreatment. There were significantly higher odds of undergoing an episiotomy for those who felt pressured by a healthcare professional to induce labor, those who felt pressured to use an epidural, those who identified as non-Hispanic Asian Pacific Islander, and those who had less than a high school education or a high school education. Ultimately, having a midwife attendant at birth was the most protective factor of not receiving an episiotomy. The odds of having a choice in undergoing an episiotomy was significantly lower among those who felt pressured by a healthcare professional to use an epidural, among all racial ethnic groups except those who identified as non-Hispanic Black, and those who had an income less than or equal to $40,000, who had Medi-Cal insurance and a high school education. However, when it came to having a choice, those who indicated ever being handled roughly or physical abuse by a nurse or provider were 95% less likely to have a choice in undergoing an episiotomy. Although this study came with many strengths, there are limitations. This was a secondary data analysis, which means we did not collect the data. And it was a cross-sectional study with self-reported measures that comes with its own barriers and challenges. The statewide survey is not necessarily representative of the United States population or the proportion of births in the US. So for example, like I pointed out earlier, almost 50% of the respondents were Hispanic and Latino mothers, which is a very high proportion for representation of the US population. It's more reflective of the demographics of the state of California. The unnecessary performance of episiotomies and lack of informed consent is a form of obstetric violence, and our findings do align with prior studies indicating that certain sociodemographic groups, especially those who are marginalized, such as by your race or income, insurance, and education, are more likely to be victims of obstetric violence. This study is the first of its kind to examine other forms of obstetric violence as predictors of undergoing an episiotomy and loss of autonomy. We have submitted a manuscript of this study to the Birth, Issues, and Perinatal Care Journal. So we do ask that you do not share our findings yet until it is hopefully published very soon. And these are my references, and I thank you all so much for your time.
I'm sharing my screen. Can someone tell me if you guys can see it?
Yes, we can.
Yes, we can.
Thank you. So hello, everyone. Good morning, good afternoon, good evening, wherever you are. So my title of my presentation is Challenges of Community Organizations in Serving Survivors of Human Trafficking of Racial Ethnic Minority Youth and Youth with Disabilities. And I did this study with my colleague, Dr. Blanchard, and two of my students. So I am Sarbinaz Bekmuratova, and I am an assistant professor in the Department of Occupational Therapy at Creighton University. But like Michelle mentioned earlier, I also serve as a program planning committee co-chair for Women's Caucus for the APHA. I also serve as currently a chair-elect for Human Rights Forum at the APHA. So before we dive into the study, a little bit of background. So according to the National Human Trafficking Resource Center, over a quarter of identified survivors minors, and the age that they've been recruited to trafficking were between the ages of 12 and 17. And with that, in the recent years, the attention to human trafficking, particularly to domestic minor sex trafficking, have been growing lately. So scholars have identified, have focused on it. And so the current body of literature identifies certain groups of youth as high-risk groups. And so those include homeless and runaway youth, youth that belong to sexual minority groups, those with history of trauma, abuse, and neglect, and those who are involved in different systems, systems being juvenile justice, criminal justice, foster care, and child welfare systems, youth that experience domestic violence or other types of family dysfunction, and those with history of substance misuse. However, there's not much known about other groups who might have a heightened vulnerability to human trafficking. So there are two other groups that are currently emerging. So the racial ethnic minority youth and youth with disabilities. So if we look at the statistics in sex trade, we see racial disparities. So for example, in South Dakota, 40% of sex trafficking victims are Native Americans, but Native Americans are only 8% of the South Dakota population. Here in Nebraska, 50% of individuals sold online for sex trade are African Americans, but African Americans are only 5% of Nebraska population. And if we look at the child sex trafficking statistics, we see a similar scenario. So those were mainly statistics from the organization's reports. However, so it's very limited studies. That's scholarly studies that looked into these two vulnerable youth populations, but there are some. So Fidina and colleagues found that racial and ethnic minority individuals had more than twice the odds of being trafficked as minors compared to their white non-Hispanic counterparts. And some other scholars who used the data that was derived from juvenile courts, child protective services, or medical facilities reported that 38% to 80% of domestic minor sex trafficking survivors are Black females younger than 24 years old. This particular findings might reflect the overrepresentation of Black youth in the juvenile system, and may not have enough, evidence to support this claim at this point. However, nevertheless, this statistics are very alarming and requires further attention. So if we look at the other second youth group, youth with disabilities, some scholars also found that youth with disabilities, particularly those with intellectual disabilities, are at heightened risk to become sex trafficking victims. And additionally, some other scholars found that they have elevated rates of various forms of sexual victimization. So with that, in our study, we posed this research question. We wanted to look at what challenges community organizations face in serving survivors of human trafficking among these two vulnerable youth populations. I wanted to note here that this is part of the bigger study where we actually explore the micro and macro level risk factors and protective factors among these youth populations. So with that, what we did, we invited Nebraska community organizations that provide services to human trafficking victims and youth at risk. And so we completed a total of 22 interviews with them. So the interviews all happened via Zoom, lasting 60 minutes each, and we collected data between September and December 2022. And we did content, oops, I'm sorry. And we conducted inductive content analysis for data analysis. I apologize, there's something going on with my screen. So here's the sample characteristics. So the participants in our sample, their years of experience range from 1 to 25 years. As far as the educational background, it varied, as you can see on your screen. Their job positions and titles also varied. And we also asked about their human trafficking training that they received. And so majority of our participants, 17 of them, received either advanced or some type of specific to human trafficking, training. But 5 of them reported that they have never received any training specific to human trafficking. So these are the themes that emerged from our data analysis. So I'll go over one by one. So the first theme is on lack of ongoing caring adult. So we, like I noted earlier, so when we explored the protective factors, risk and protective factors, organizations noted that having an ongoing caring adult for youth survivors was helpful to prevent youth from relapsing back to traffickers. And so organizations were trying to provide that ongoing, caring adult that will work with them and be there for them, but this was a very challenging task for them to have that ongoing adults who might provide that support on a regular basis. The next theme is on establishing trust with survivors. Organization representatives noted that they lack culturally diverse staff, tailored services for youth from various backgrounds, diversity of languages, and properly trained staff to work with children with disabilities, and also male service providers to work with male victims, for example. And so all in that combination was making it very challenging for them to establish trust with youth. So one of the participants said, with different ethnic backgrounds, I think automatically you're seen as an outsider, specifically the Muslim population. If you're not part of their world, they're not even going to talk to you. In fact, they will be definitely punished for talking to you, specifically for women, for sure. Another participant said, we would love to have someone on staff that knows all these different languages, but we don't have. We can use an interpretive service. That's great. What do you do when someone can't speak English and they want to be part of your program? That's a challenge. That's a real big challenge. That's where we feel that we have failed at. So next theme is on wanting to relapse back to trafficking. So most youth lack awareness of that they're being trafficked and what's being done or what have been done to them is wrong, and they always have this constant desire to go back to their traffickers because the traffickers were fulfilling their various needs, emotional and financial needs. So one of the participants said they don't necessarily think that they are being trafficked, and so to convince them otherwise is tough. They may not want to leave their life because they may be getting something that they need, whether it's money or attention or affection. They're not always willing to let that go and start over with a new life. The next theme is on structure of systems that mimic trafficking experience. So system, again, here referring to various systems, including the foster care, child welfare system, or juvenile systems. So The representative organizations highlighted that the structure of systems that use once they exit their trafficking experience, when they are involved, it mimics their trafficking experience, because in that system they don't have any power or choice over their life, and that doesn't help the youth to heal from their trauma. So one of the participants said, our healthcare, one of the things that I see a lot with victims who spend time in foster care is they don't want to access healthcare or psychiatric healthcare because they often been court ordered for years to take medication or to go to therapy and haven't really had any control over the bodies in a lot of ways. So it mimics the trafficking experience. So next theme is on the lack of services for children with disabilities. So organizations noted that they lack tailored services for youth survivors with disabilities locally, but they also acknowledge that this is an issue nationally as well. So one participant said, I think it does come down to relationships, but also comes down to availability of services. So when you're working with someone who may never be seeking a job, or the ability to process feelings and events, that having developmentally appropriate supports that offer protection and learning and connection is something that just does not exist in Omaha. But I don't think not only in Nebraska, but around the country, it's a problem. Next theme is on lack of ongoing and long-term services. So Nebraska is a rural state, and so all organizations, particularly in the rural areas in Nebraska, noted this as lack of ongoing services to address survivors' complex needs for physical, mental health, substance use, and housing being a great significant challenge. And the last theme was on collaborating with other organizations and funding to provide resources for survivors. So the organization representatives noted that it's challenging for them sometimes to collaborate with the organizations in the same locality and find funding to provide services that that they will be able to provide to meet all the youth survivors' need. So our study had limitations and strengths. So the limitations, obviously, we didn't interview youth populations, so so their voices are not reflected in our study. The sample was limited to only the Midwestern state, Nebraska. However, we did, by interviewing the community organizations, we captured their perspectives on micro level and macro level challenge that they face in serving these youth populations. So with that, our study has several implications for policy and practice. So first of all, for organizations that serve these youth populations, we would recommend developing tailored services for youth with diverse ethnic backgrounds and youth with disabilities. Also, along those lines, increase diverse and trained staff to assist these youth populations. For the systems, we would recommend improving services of various systems for youth survivors of human trafficking, providing for them more freedom and choice so that it will facilitate their healing journey. And lastly, for policymakers, we would also urge them to increase funding opportunities for community organizations that serve youth survivors and at-risk youth, especially in rural areas. So I would like to end my presentation with this quote from one of the participants who talk about anti-trafficking work. When we think about anti-trafficking work, we always, or people tend to think it's something has to be really, really, big. However, it doesn't have to be. So I'll quickly read it. I always tell people when they want to get involved in trafficking work, anti-trafficking work, I always say, you're working with people to have stable housing. You're working that the law equally protects people regardless of their sexuality or their race. If you're looking or waiting or helping people, boys understand healthy relationships and the role of women in relationships, you're doing anti-trafficking work. So here are my references. Thank you very much for your attention, and I'll take any questions you may have.
Thank you so very much for all of our presenters. We'll get to questions and answers in just one quick second, but I just wanted to let everyone know that we'd appreciate your feedback on this webinar. This link is in the chat box, or you can scan the QR code to access the very brief evaluation. It also provides an opportunity for you to provide us with examples of other topics that you want to listen to through our webinar series. So please take some time to complete that. Also, for those of you who arrived late, please check us out on our social media and our website. We do have a call for abstracts open until March 31st, so consider submitting your abstract to the Women's Caucus. So with that being said, I would like to open the floor for questions and answers. And feel free to unmute yourself, or you can put your question in the chat box. Okay, excellent. So we have a question from Dashana. She says, thank you all for your presentations. Dorian, what are the next steps based on your findings?
So I think it's important to note that this data was collected prior to the COVID-19 pandemic. So I would guess that obstetric violence, obstetric racism has increased or exacerbated during the pandemic because people were not allowed to have supports at one point during labor and birth. Lots of hospitals have gone away from that, but they're still strict on their policies with maybe one visitor. And so the less support that you have, the less advocacy that you have, the less control that you may feel that you have because your support system's not there, whether that be a doula, a partner, a midwife. So I think that it's important to look at the rates of obstetric violence prior to the pandemic and after the pandemic, and how those sort of policies are possibly worsening outcomes. You know, although we look at traditional birth outcomes like having a preterm birth or an infant death as a health outcome, I believe that patient satisfaction and having a positive birthing experience is also a outcome that we should be looking at. And so when people have their autonomy taken away from them, that matters just as much as whether or not they are physically or biologically healthy. So I think that would be a good next step for this. Thank you for your question, Dashonda, and thank you for the compliment.
Other questions? Excellent question. And presenters, feel free to ask questions of each other if you have any questions. No questions? All right, well, thank you all so very much for attending. Again, thank you to our presenters for the amazing work you're doing in the area of women's health. We encourage you to keep going with this work because it is much needed. And yes, Claudia, I agree, very interesting work. And so everyone, thank you all so much for attending. We appreciate you attending our first webinar for 2023. So be on the lookout for additional webinars from the Women's Caucus. So thank you all so much, and I hope you enjoy the rest of your day.
Thank you, Dr. Williams. Thanks for the opportunity.
Thanks
Thank
for
you.
Thank you.
Thank you.